Hello everyone. We are very delighted to have a very special guest with us, Dr. Abhirup Banerjee. Hello. Dr. Abhirup Banerjee is a Royal Society University Research Fellow and Principal Investigator at the Institute of Biomedical Engineering, University of Oxford. His work is truly at the cutting edge, using on engineering and understanding biomedical research. So great to have you, Dr. Banerjee, here.
Thanks for having me.
You have been on campus for a short while. How has been your experience so far at IISER?
Technically, it's my second time into the campus, so I have my previous experience, and I really love coming here. It's a very beautiful campus. It's a very beautiful place. It's a very vibrant. People are excited about their work, and actually, the students are equally interested as the professors, and everybody is trying to solve the problems together, and that's what the aim of our science, right?
Correct. So going to your research area, could you explain it a bit, like the work that you do at Oxford University?
So my work is, if you can try to use it in one word or in three words, it's going to be multimodal digital heart. So that's my name of my project. But I'm talking about the human heart. I'm trying to recreate the human heart based on the fragment of the information available clinically. So when the doctors try to capture the heart, they capture some information either in the 2D or the 3D, spatial or the temporal. So all you get is a piece of the Lego or the puzzle. And how we actually combine those small pieces of the Lego, we join them all together and create the actual heart in a digital space. And when the multimodal coming, because heart is about vasculature, the muscles, the mechanics, the electrophysiology, electromagnetic, all those things together. So how you combine all those things together into a dynamic heart, into a digital space, and help the doctors to do diagnosis as well as intervention. So that's the aim of my team, which is called the Multimedia Lab, Multimodal Medical Data Integration and Analysis Lab. That's what I do together.
Very interesting. So it's very interesting, and I would say this is very much of everything: maths, engineering, biomedical, all those things combined.
Exactly.
So your answer, actually propels me to ask: how do you, convince the clinicians or the doctors to use the research that you do? Or it's
Fantastic.
Very
I don't know whether this is the common approach, but I have a little bit of philosophy. That's what I believe in. I often say to my team is that don't invent the question, because there is already too many questions in the world. The doctors have a lot of questions, so don't invent the question yourself. Ask the doctors what their question is, and we can try to answer that question. Because we are computational people. Maybe we are mathematicians, physics, chemistry. So we are good at or we are decent at answering the questions. So in my lab, we try to answer the question the doctors are having. For example, if we take the images into the cath lab, it's a real-time imaging, or we get information in the 2D, right? So how we can just take the multiple 2D information and create the 3D structure of the heart or the geometry? Can we use that and just take those information without putting an extra pressure where measure the blockages, measure the blood flow? Can we reduce the radiation? Do we need to take the images always, or you can reuse some of the previous acquisition? So our job is to help the doctor. This I'm talking about the intervention or surgical perspective. It can be diagnostic perspective. For example, should we only take the images, but then we are missing the shape information? How we can create the shape information just based on the available data? So the doctors have this question, and we try to answer those questions, because that way the doctor, we don't need to convince the doctor. Doctors are already convinced about the problem. We are trying to give them the answer, and then they can judge. And the doctors need to be involved in every space. For example, in the student level as well as the professor level, it needs to be equally doctors as well as the computational people. When I say computation, it's as you said, maths, engineering, computer science, physics, all those people needs to be working hand by hand. This needs to be a truly collaborative, because there is no subject, there is only problems.
Understood. But I'm still anchored to the point. How does a doctor come to believe the research that is going on? What evidence do they have? Do they have any primary results or something, or they can match with? How exactly to convince those doctors to believe in the research that we do? Another question is,
Okay, no worries. Let me answer that first. So, absolutely great question. So, your solution can never be a black box, right? Because if it is a black box, often we don't know how the model is working. So
Correct.
your model needs to be completely transparent. It needs to be, if you say white box, or your model needs to be interpretable, because it needs to be based on our knowledge. When I say our knowledge, it needs to be our computational knowledge as well as the clinical knowledge. It needs to be completely aligned with the doctor's knowledge, and based on that, they can say, oh, if this is consistent, then this is gonna work that way. Like for example, if I take a very simple idea, if you talk about reconstructing the coronary vessel, like if you have the 2D images, 2D angiogram, assume that, and you're trying to reconstruct the 3D structure. Why I always get back to that, because this is the first problem I work on when I went to Oxford. Now, if you think projection, what is projection? It's the shadow, right?
Correct.
Now, if you have two shadows, the question is, can you get back the object? It can, because if you know the light path, so essentially, if you know where the light comes from, where the shadow is, the object is actually gonna be at the intersection point, right?
Yeah.
So you can create those intersections, and from the intersection, you can get back the object. If the doctors can actually see how the light is going to the object, if you can simulate their whole machine, and from there you can show that where the digital object, digital person is inside, then they can literally see that what is going on in the physical space is literally going on in the digital space, and they can clearly, completely transparently see that. So that maybe, I'm not saying this is the only way, but this is the way I follow. That just literally recreate that what you're doing in physical space to digital. They can see through it, and they can completely trust that, because nothing is hidden.
This is truly interesting. I mean, seeing your own heart, in the doctor seeing your heart and then diagnosing is really inspiring.
I didn't mention that. Sorry, I should have said that. In my desk, I actually have my own heart, 3D printed. So literally, you can hold my own heart. So, of course, 3D printed material, not the biological heart, but I have a 3D printed heart. I can show them, because this is my actually heart. So if you can take your heart, I can create your own heart, and the doctors, you can hold your own heart there. It's not like someone's theoretical heart. It's a practical one person. You remember this is called the personalized digital twin. Sorry, I didn't mention the word during the podcast. Is that my work is about personalized digital heart or patient specific heart, not like a generic heart, but heart of your own.
Understood. So very, very, very inspiring. I wanted to know, you work at Oxford, and the kind of population that you deal with, and the kind of people and the geographic things that you deal with are very different from what you see in India. So my first question is, how do you see, the same technology being adopted in India? And second thing is, how does it differ from there and here in India?
Fantastic question. So I'm assuming your question is about the ethnic diversity there.
Correct.
Huge. Because when you're talking about the yes, UK also has a lot of South Asian population, of course. But yes, many of the model I work, like you remember, I was talking about 11,000, 10,000 heart before. So those are often the white Caucasian population's heart. There is a less South Asian diversity there. And if we talk about South Asian diversity, we have a huge diversity there. So sometimes our models need to be adapted there. Now, when is a model adapted? It's a very good, again, a nice point is that we can create a machine learning model from a data-driven. But the question often comes is, are those models generalizable? So generalizable machine learning model is another different field. So developing a generalizable model there is very important. And when it's a generalizable model, that means the model needs to be robust to the ethnic diversity or some of the diversity from the demographic diversity or the protocol of the people, a protocol of the operator. Sometimes image captured from one machine, if you train a model from there, apply to another machine may not work there because there's a machine level variability. So your model needs to be generalized enough. So essentially that's why the transparency, again, the previous point, you're talking about transparency, right? Your model needs to focus on the pathology or the anatomy rather than the image variation or the domain specific variability there. So the generalizable model is one way to go, and then the model needs to be, of course, deployable because South Asian also have a variability there, right? So you can try to make a generalizable model, but it is also possible that the South Asian heart are also very different because we have a high amount of hypertension, diabetic population with a diabetic capital, right? So then the model needs to be also exposed to those pathologies also. So in order to apply a model developed for one place, you need to also train the model, retrain the model, fine-tune the model into South Asian population. And for that, also the model needs to be generalizable and also low cost because our resources are also constrained sometimes, right?
Correct.
The model needs to, you cannot apply a model which requires a very high amount of GPU. You need to make a low computationally powerful, the low, integer, it's not the right word, but the model which can be used from the less amount of resources.
Correct. Yeah, and I even can feel that we need also a completely different kind of data for the. In India, we see a lot of variability. North India, South India. My next question is more student centered. So I want to know. See, this research is culmination of lot of fields, maths, stats, and everything, combining all the deep learning, all the AI goes in. What do you know? How do you? And this also looks like very time consuming. By time consuming, I mean the research output is very slow as compared to other fields. So I'll just give an example. So somebody is working on some problem, they do it and they get the results in some 3-4 months. But I think this research that we are doing here is actually taking years of effort. So how do you motivate the students to stay motivated enough to work on these problems for long?
So, okay, firstly, answer one part is that if you are doing longitudinal study, then it can be time consuming because then you can see a long term outcome of some diseases, right? But if you're not doing a longitudinal study, it's not that slow.
Okay.
Because, for example, if I'm creating your heart reconstruction at this current time point, I can do it instantaneously, right?
Okay.
I can do it in minutes actually.
Okay.
So I don't think that's a time consuming. And the outcomes from the medical imaging field is also very fast, right? For example, some of the techniques I'm using, I was talking about the 4-chamber reconstruction of the heart. Some of the models I've been using, which is actually published this year, 2025. Okay, now it's the last year's, AAAI and the CVPR. And then we actually try to improve from there and try to adapt it. So essentially, we are trying to create theory for the application, right? So we are trying to adapt it for the cardiac structure. So they are not that time consuming. So the publications, and we also the place where you publish from the general AI, like AAAI, or the generally the computer feature CVPR, WCV, ICCV, is the same with our field also. It's not that slow. And the motivation part is a very different question because the people who are in this field, they need to be pretty much motivated because most people have a personal reason because we are talking about medical, right?
Mm-hmm.
So I am not that interested in the data. Okay, of course I'm by trade as a statistic. I didn't mention that. Of course I like data, but at the other side is the cardiac disease is very personal to me. My grandfather when he died, he had the 7th stroke actually, like the 7th. I don't know what is the Guinness World Book record there, how many stroke a person can have. But when he died, it was his 7th stroke. So myocardial infarction or heart attack is very personal to me. And everyone has it. In India, every family has so many heart attacks, cerebral stroke. So it's our problem. Diabetes is our problem. Hypertension, when I say our, it's a South Asian problem, right?
Correct.
So it's a very personal thing. So many people who comes here in this field, they feel it very personal about it.
Yeah, I mean, lot of reasons to stay motivated.
Exactly.
My next question is, if somebody wants to follow the same path or wants to do this similar research or get into and actually proceed this research to further level, what steps would you suggest for the students?
It's a great question. So mine is probably not the best answer because I did my undergraduate and postgraduate is in statistics in Indian Statistics Institute. Then I did my PhD from Indian Statistics Institute in computer science. And then I went to Oxford and my first department was in the medical science. And then when I got my permanent position, not my faculty position, my Royal Society fellowship, then I moved to the biomedical engineering. So first, in statistics, as a student, undergraduate, postgraduate statistics, PhD computer science, first job in the medical science, got my fellowship into the biomedical engineering department. So this is probably not the best route, but if you also see that everything somehow, for some reason, I don't know how it happened, but everything I did that kind of prepared me for solving this work.
Yes.
So somehow it worked. But if you also try to see a common thread, all I was doing is solving problems. I was first solving the problem where the data follows Gaussian distribution, and then I'm solving a problem where the data doesn't follow Gaussian distribution. But I'm solving the problems there, right? So if you think like problem solving perspective, at the end of the day, it is actually it's the passion which is the first thing needed, and then the problem solving mentality, and then some of the training, you can be someone from the physics background, someone from the chemistry background, someone from a pure maths background, statistics background, computer science background, any kind of streams of the engineering background, can be data science, can be mechanical, can be electronics. But at the end of the day, we need people from all those backgrounds because we are trying to solve a global problem that kills 1/3 of our population, right?
Correct.
So it's not one person's job. We need everyone's. We need every expertise is possible.
Correct. So I see. I mean, the theorists need not to be demotivated. They can always
Not at
switch
all.
from
I came from
hardcore
theory.
statistical theory to the 100% applied biomedical engineering
Exactly.
research. So before we conclude, I have one final question.
Mhm.
Where do you see this technology in the next 5 years? I mean, what is the next big milestone for the word, and I would say I want answers for India specific. Yeah.
So the way I envision, why I am very passionate about it, is that I want when the patients come to the hospital, the doctors take the images, right? But then before doing the surgery, doctors can start with the surgery. Essentially surgery is the poking inside the body and see if it works or
Yes,
not, right?
yes.
Now those poking can be done inside the computer. So before start doing the surgery inside the human body, let's do the surgery inside the computer. Like I kind of say that the doctors can play the video game inside the computer and see which works, because in the human life you have only one life, right? When you do the video game you have the three life or like infinite lives, right? So play the video game inside the computer, see what works, and then apply to the human body. That's what I dream. I don't know whether it's going to be possible in the 5 years or not, but the techniques I am developing can be used for the not only the high income country, but always, because my focus is in the applying for the low income country, right? So not even in India, like even poorer countries than India, but anywhere. And that's why I try to develop technology which is the low resource settings which can be applied, and the doctors can actually see the pre-treatment planning before doing the human body, and can even see that how much is the impact of that. So I want to do that digitally before looking at the human body. Let's hope that we can do as soon as possible, but that's the dream I have.
Very, very nice. I mean, this is truly inspiring, and I hope this motivates a lot of people. Any final advice for the students?
My only advice has always been is that follow your passion,
Follow your
because
passion.
if you follow your passion,
Follow your
you can move the mountain.
Correct.
It doesn't matter, right? If you have the passion, wherever you started from, it doesn't matter. Any expertise you have is useful for solving problems. It doesn't matter where you from, and essentially, if you have the passion, you can solve anything.
Correct. Thank you,
Thank you
Dr.
very
Abhirup. Thank you. We are very happy to host you here. Thank you.